So we welcome everybody back for our next series and highlight of the latest research covering non-clear cell kidney cancer or variant histology kidney cancer, which Chromophobe falls into as well too. So we are very excited to talk about this study that was covering IPI-Nivo in patients with variant histology. We are so excited to have Dr. MJ Moussa with us here. He is going to kick us off and share a little bit more about this study with us. So, Dr. Moussa, can you explain this study and introduce yourself to everybody listening?
Of course, thank you so much, Katie. Really appreciate the chance to talk to you today and present our research. So my name is Mohammad Jad Moussa. I go by MJ Moussa. I'm a postdoc fellow in genitourinary medical oncology at MD Anderson Cancer Center based in Houston, Texas. I've been doing research for the last 2 years on rare GU cancers with unmet therapeutic needs, focusing on kidney cancer and bladder cancer. I'm mentored by Dr. Omar Al-Halabi and Dr. Matthew Campbell, both of them who are professors at MD Anderson. I'm very happy to be talking to you today about this interesting topic of non-clear cell or variant histology renal cell carcinoma. And Katie has been doing a wonderful job and has been an advocate for many patients in this space. So very excited, very happy to be here.
Yeah, thank you. And we are excited as well too. One thing that I think would be really great to kick off and start with as well too as we dive in is I know we might kind of use the terms interchangeably and they can be there's divergent histology, variant histology, non-clear cell histology. Can you explain a little bit about what the differences are between those, if there are any, or if it's basically kind of different terms describing the same entity?
No, thank you so much for bringing this up. I pretty much understand, even as a trainee myself, that it's very confusing to understand the terminology, which is constantly changing. And I understand for patients, it's even harder when they, go to search that term or search that disease. But that's understandable because, science is changing and we're witnessing a great revolution of like treatments, of targeted therapies, and even of precision oncology and a new way of looking at cancers. So this new approach is making us kind of change our terminology with time. So that's why what you would see, for example, as papillary type 1 or papillary type 2 doesn't exist anymore. It has been kind of refined. And this also pretty much applies to another part of kidney cancers as well. So clear cell renal cell carcinoma, ccRCC, is the most frequent type of kidney cancer. It kind of covers around 75 to 80% of kidney cancers. The reason why it's called clear cell is very simple, is that when the pathologist just goes and looks at the slide, they see that these cells are very clear because of the deposition of lipids and sugars, which kind of make the cancerous cell look kind of very clear on the microscope. While non-clear cell renal cell carcinomas are much more of a rarer subtype, which kind of covers, I would say, around like 20% to 25% of kidney cancers, and they cover a huge family and they encompass a huge heterogeneous group of cancers that might come from different origins or from different cells. And within this type of like non-clear cell renal cell carcinoma, we can identify papillary RCC, we can see Chromophobe RCC, we have renal medullary carcinoma, we also have collecting tube carcinoma, and we also have even a very particular subtype called unclassified, or not yet classified, I would say at least, that is even being further refined. And if you look at the recent like classification of the World Health Organization, this particular group of like unclassified is becoming rarer and rarer as an entity itself, because due to the advent of precision oncology, we are able to say like this is an ALK1, rearranged kind of kidney cancer. But well, this one is driven by such gene. So this revolution is really making us change our terminology, and I really appreciate patients kind of just keep up with us with this huge revolution. Yeah.
Yeah, it's really helpful context, I think, for patients to know that where you might have seen something called non-clear cell in the past, if you see something called variant histology, it kind of is encompassing exactly what you're talking about here, right? Is kind of learning that it's more than just clear cell and non-clear cell, that there's all kinds of variants in it. So very helpful context to kick us off.
This is just a small slide deck for us to run through so that we can kind of discuss together that study. Of course, I would greatly appreciate your questions. Even if somebody would like to reach out to me, they're more than welcome to. I hope I just don't make it as, scientifically verbose as possible, just to make it, make it in lay words for our patients to understand this. And so that's a really big honor. And thank you so much, Katie, for allowing me this. So our paper is called Efficacy and Safety of Nivolumab plus Ipilimumab Nivo IPI in patients with metastatic variant histology or non-clear cell renal cell carcinoma. The work has been co-mentored by Dr. Omar Al-Halabi and Dr. Nizar Tanir. Dr. Al-Halabi is my mentor, and Dr. Tanir is a huge kind of leading person in the field, and I really appreciate this chance to mentor me through this project and try to understand the outcomes of disease. I really learn from their expertise. The work has been published in the Journal for Immunotherapy of Cancer, which is the official journal of the Society for Immunotherapy of Cancer, SITC. So I have no disclosures here. I definitely just wanted to say that what we're discussing here is for pure research intent so that we can all kind of learn, as researchers, patients, physicians. But of course, like any direct medical advice should be just provided for your oncologist or to your treating provider, so that just we make sure that what we're discussing over here is for the fact of learning and for sharing knowledge. So I really appreciate it. So just to start with a small background on a Nivo IPI on variant histology renal cell carcinoma, I would like just to report on a very important phase 3b/4 trial called the Checkmate 920. This Checkmate 920 was literally the first trial which reported on Nivo IPI in a non-clear cell renal cell carcinoma, and they reported an objective response rate of around 19.6% in 46 treatment-naive response evaluable patients with VH-RCC. So what is objective response rate? That means patient who had an objective response shown radiographically was either a complete response or a partial response to that therapy. So, and among these patients, we could definitely see the breakdown of unclassified, papillary, or Chromophobe RCC, because these are the most three frequent variant histology subtypes. And there are a few rare subtypes included, but it's a small number. So our study, it will be kind of pretty much similar to that study in terms of the distribution of the subtypes. The responses in the study were exclusively seen among patients with PRCC and URCC, which is papillary RCC and unclassified RCC. And the presence of sarcomatoid features was noted in 14 patients. So we saw a very interesting overall survival, a median overall survival, as you can see over here, of 21.2 months, while the median progression-free survival was 3.7 months. Why is that important? Because it was the first time to know outcomes to Nivo IPI in this population, as compared to the limited evidence we have from small retrospective studies in VH-RCC, where the ORR was kind of ranging between 30 and 36%. And definitely some other studies were looking at Nivo IPI in subsequent lines of treatment. So in this study over here, where they just focus on first-line Nivo IPI for locally advanced or metastatic disease in variant histology renal cell carcinoma.
This is all fantastic information, I think, to kind of highlight where this has kind of already been looked at as well in kind of a larger trial. A few things that we can expand on a little bit for patients here. Can you explain what a phase 1 3b/4 trial is for patients, as well as some of the other terminology, like what objective response rate or ORR is, overall survival, and progression-free survival, to kind of help define what some of those terms are?
Definitely, Katie. Thank you so much for that question. A phase 3b/4 trial is an advanced stage of clinical research. So the way how drugs are usually approved, before they kind of reach the final stage of approval by the FDA and being sent into the market, is that they go through different stages of approval. So this starts with a phase 1, then goes to a phase 2, then a phase 3b/4, and usually there are some what we call some post-marketing phases of looking at that drug. So definitely all research starts from preclinical data, where research in the lab happens and tries to look whether there's an evidence of response or some interesting stigma of response to a certain drug or newly developed drug targeting a specific agent, usually either in patient-derived xenografts, which is samples taken to the lab and literally investigators test directly the drugs on them, or even in mice, which where investigators make models to try to simulate the disease of human beings. When there's the evidence of response in the lab, the drug is taken to a phase 1, where we try to understand the safety of the drug, whether it's safe to be administered for patients. Sometimes in oncology, that might go through dose escalation phase to try to understand what is the dose best fit for the patient and what is the safest and the most effective dose of that drug. After phase 1, it goes to phase 2, where phase 2 usually is kind of limited on a smaller population, where we try to investigate the drug, usually in a single arm, where a single arm, which means kind of in a single population and not compared to a different arm of patients receiving standard of care. And when we see that there's another kind of stigmata of response in this population, we take it to a phase 3B or 4 trial, where usually over here, that means like the investigators have an intent to treat population, or as they go per protocol, where they have a very specific methodology to try to understand the efficacy of this drug and usually compare it to the standard of care in this disease. For example, like we know, that's why we see in most studies in kidney cancer, we have sunitinib, which is usually used as the comparator, and it's kind of being used, words like like compared to these new therapies. So here we trying to understand the efficacy of the drug on a larger scale in a very strict methodology on patients with two arms. And then after that, we have the post-marketing phase. An objective response rate is actually the percentage of patients who show a radiologically proven response to the drug. That can either mean a complete response or partial response. Now, there are some specific criteria, something called the RECIST version 1.1, which is kind of the most frequently used criteria, very kind of standardized guidelines for researchers and investigators to use them, where we try to understand how that, like a specific target on radiology just grows or shrinks depending on the drug. So having a complete response means, that this target lesion has just kind of completely disappeared, or at least has undergone a huge shrinkage that makes it feel, that just makes it very safe for the patient to not have further disease progression. And a partial response means that usually this target lesion has usually kind of shrank to a smaller degree, probably not to the point of being disappeared, but just that shows an evidence of response as compared to progressing or just continuing or growing further.
Perfect. And that's really helpful context. And
So in our study over here, we're doing, this is basically a retrospective study, a 55 patient with metastatic VHRCC or non-clear cell, again, at MD Anderson from November 2017 to November 2024. What does a retrospective study mean? It actually means that we're looking at all patients, back in time, who received Nivo-Epi at our institution, and we look at their outcomes. This is kind of sometimes called as a real-world evidence. And of course, in statistical methodology, this is a very valuable use of information to try to understand patterns and responses to a particular drug, especially when actually the disease is very rare and we cannot have the phase 3B4, or what we call the prospective trials, to try to test certain drugs on it. So especially for rare cancers, Katie, and as you know, you've been a great advocate in that space, we rely a lot on these retrospective studies because first, they simulate reality. Two, because the fact that we got just by nature, we are limited by numbers. So we try as much as we can to learn, from these patients and from their samples. And third, I think that we can always kind of try to compare and contrast them with clinical trials if they are done, so that we can try to see how the design of the trial just differs from the real world evidence. And this is very super insightful for oncologists and treating providers to understand that. In that case, for example, we exclude patients with VHL mutations by next generation sequencing, because patients who have VHL mutations in their tumors are usually kind of considered to have clear cell renal cell carcinoma. And this is not our research of interest over here. So this is kind of more, I would say, like a step for us just to guide our research and make sure that we're kind of just looking at the right thing. And we also pay attention to the impact of sarcomatoid features on response and survival outcomes. And definitely this will lead us to understand more how the response to Nivo-Epi is driven by the presence or the absence of these sarcomatoid features. And we also finally include data on next generation sequencing, which means kind of a molecular dissection where we kind of go look into the transcript, into the molecular aspects of these cancers, try to see what are the mutations out there, what do they look like, and we try to link these mutations to the response outcomes so that we can learn later on probably that this is a subset of patients who have this mutation in their tumors. So probably they might respond to X drug or to Y drug. So here, how we kind of heading towards an oncology. 35 patients received induction Nivo-Epi only, while 20 patients received maintenance nivolumab. Maintenance nivolumab is usually initiated after 4 cycles of Nivo-Epi. And in that case, this means that patient just underwent the full treatment of induction Nivo-Epi, and because of good response, they went to maintenance nivolumab. While 35 patients here, they just received up to 4 cycles, which can include 1, 2, 3, or 4 cycles. And this is striking to us because if you look at the Checkmate 214 trial, trial, which is kind of what studied Nivo Ipi versus sunitinib back in clear cell RCC. Actually, around like more than 3/4 of patients, they completed all 4 cycles of induction of Nivo Ipi, right? Because patients who had like just a 1, 2, or 3 cycles, less than 4 cycles, they were taken off protocol and they were ineligible for maintenance nivolumab. Well, if we look over here, we have a much more bigger number of patients who were not able to receive maintenance nivolumab, and this kind of just shows to us how much this disease is aggressive and how much sometimes like many of these patients are not able to see further lines of treatment. However, we just try to understand their outcomes and try to see more their patterns of response. For the baseline characteristics of our cohort, this helps us understand what we are dealing with, right? Because sometimes, of course, like many investigators always try to report OS and PFS, but we need to put that in context of the characteristics of the population that we are studying. So for example, in our study over here, we have sarcomatoid differentiation happening in 36.4% of the samples here in our study. And most patients actually were treatment naive. That means they did not receive a prior line of therapy. And this helps us know the true value of Nivo Ipi as a first-line, front-line treatment for advanced or metastatic renal cell carcinoma in that setting. And for the metastatic disease sites, we try to understand the disease burden in these patients. We try to know like what is the metastatic pattern, where did that disease go? Did it go to the lymph nodes, to the lung, to the liver? And in that case over here, we see that the lymph nodes and the lung and then the liver were the most frequent sites of metastases in these patients.
Yeah, I think looking at this data here, it's interesting when you look at the comparisons of sarcomatoid features from Chromophobe versus some of the others. There's a lot more papillary cases, more than roughly double. But you can see that there's more sarcomatoid in the Chromophobe cohort. And so I think that's a very interesting piece of data just to pull out of there.
Sure, it is. No, thank you for observing that, Katie. So this is a typical example of how oncologists try to build on preclinical evidence to try to guide their treatment. So we know that, kind of Chromophobe RCC is more immunologically cold, which means it's less responsive to immunotherapy as a disease itself because we know that it has a lower TMB, it has a lower PD-L1 expression. However, the sarcomatoid component of that happens in the disease is paradoxically even more immunologically responsive. It has like overexpression, I would say, of PD-L1. It has a higher tumor mutational burden. So the reason why probably we have a higher representation of sarcomatoid differentiation in Chromophobe is that the treating provider wanted to see the efficacy of immunotherapy in this particular subset. So it's a personal preference of the provider to try to treat these sarcomatoid features in this disease with immunotherapy because we know from preclinical evidence that it's more immunologically responsive.
Very interesting. Thanks.
So this is kind of, I would say, the main outcomes of our study, the response rates. This is the parameter of the ORR, which we previously defined. So the ORR was 48% in the subcohort of patients with papillary RCC, 25% in patients with Chromophobe RCC, and 27.8% in patients with unclassified RCC. So the overall kind of response rate was 36.4% in all our patients. So to try to understand where these responses happened, we also kind of stratified by the presence of sarcomatoid features. And we see actually that most of these patients who had Chromophobe RCC with an evidence of response, they actually had sarcomatoid features. And yeah, even if we look, at the ORR with sarcomatoid features, we have a higher ORR of 55% as compared to 36.4%, which kind of led us to the conclusion that patients with sarcomatoid features have a higher response to Nivo Ipi, regardless of the subtype, whether it's papillary, Chromophobe, or unclassified. And specifically in Chromophobe, that has been striking to us because we know that in Chromophobe RCC, it's an immunologically cold disease. And we usually, primary providers were not pretty much excited to treat with immunotherapy. But in that case here, with this kind of PD-L1, CTLA-4 inhibition with Nivo Ipi, we saw evidence of response in these patients who kind of had sarcomatoid features.
So it looks like based on this table here that all of the patients that had a response for an ORR response had sarcomatoid features in the Chromophobe cohort. Is that right?
This is correct.
Yeah.
Yes.
I think it's very important, and I'm very glad that you guys helped tease that out in the study. They're very small numbers. I think that kind of happens when you're looking at rare subtypes in general, but I think it's very important to help separate out some of that data because I know that doesn't always happen, and it makes it so you might be able to find signals like this a little bit better. Obviously, still small numbers, but I think very helpful to look at. So I'm glad you guys did that.
Absolutely. Thank you so much, Katie. And even if you look at unclassified RCC, again, 4 out of the 5 responses will also happen in patients with sarcomatoid features. So this is definitely an interesting biomarker to try to look at in this disease. So just talking of sarcomatoid features to try to define it, I mean, for our patients, sarcomatoid features are actually some characteristics of de-differentiation where the cancer cells try to resemble more sarcoma, which is kind of a type of cancer that comes from the connective tissue. So it's usually a type of cancer that becomes more like what we call mesenchymal-like, where the cell goes back to its kind of old, like historical like form. So this is a subtype that is usually aggressive. So seeing these responses with PD-L1, CTLA-4 inhibition in this subgroup of patients really gives us hope and tries to confirm the preclinical rationale that this is a characteristic that is associated with more response to immunotherapy because it has a higher tumor mutational burden and it also has a higher PD-L1 expression. So this is really a wonderful observation that we've been privileged to try to look at.
Yeah, it's very helpful information.
Another way to estimate progression-free survival is to do or to calculate the milestone PFS rates. And I guess these kind of help patients and researchers as well understand more what is the probability, of progression at a particular time point. And many patients sometimes would like to understand that because the way, I mean, it's just more, I would say, pragmatic for the human mind to understand a progression event at a particular time in history, saying that the probability of progression, right, at X times of months is that number. So we can try not just to put more that into real life and understand what is the event happening at a particular time point. So here in our 6-month milestone PFS rates, we saw probabilities of 56%, 41%, and 39% respectively in papillary, chromophobe, and unclassified. Again, these are very interesting outcomes because this lets patients understand what is the probability of having disease progression at 6 months and also at 12 months as well, so that they can try to understand the response to this drug in this particular setting. Over here, again, the main message that we're trying to convey is that patients who had papillary RCC derived the most benefit from Nivo IPI. If we look at the ORR, it's at 48%, and even it was higher among patients who had sarcomatoid features. It's around like 67%. And even like the patient who had papillary RCC had the highest median OS, the highest median PFS, and also the milestone PFS rates, as well as the highest durability of response as shown by the median DOR over here of like 20.1 months. And also as well for the median TTNT. This is all parameters that helps us oncologists know and like what is the relationship of that treatment to other drugs or to other lines of treatment in that disease. So with TTNT, for example, as the time to next treatment, that means that if the patient has like a major response, they're gonna not have their next line of treatment like before an extended period of time. So in that case, for example, patients who had papillary RCC, on average, they had a TTNT of like 8.8 months before seeing, the next line of treatment. So this kind of gives us more confidence of how much this durability of the response to the drug is happening in this particular setting. Patients who had unclassified RCC had inferior outcomes with Nivo IPI as compared to papillary RCC or chromophobe RCC. Again, this is a continuous kind of area of learning because this is a subset that is hard to define. Although we tried in our study as much as we can to make sure that these patients with unclassified RCC do not fall into clear cell or do not have kind of any other bias in the diagnosis. For example, the pathologist will make sure that there's no CA9 expression, that there are no kind of morphology that resembles clear cell, or sometimes that they don't have VHL mutations. It just lets us know to try to define this subset further. And I'm pretty sure that with the continuous progress in genetics and even in moleculars and in sequencing, where definitely this group is going to be more defined and like subdivided into more like concrete categories. And these patients will have more targeted therapies depending on the alteration that is happening over. This is like the biggest benefit in precision oncology. Again, here, when when we tried to look at these patients on unclassified, we wanted to know also whether the presence of sarcomatoid features is just kind of driving higher responses. We saw a median PFS of 9.2 months in patients who had like sarcomatoid features and unclassified tumors, as compared to 2.8 months with patients without sarcomatoid features. So the reason why we tried to hypothesize why we kind of have an inferior median overall survival and a median progression-free survival for patients with unclassified RCC is that there was a higher disease burden in the baseline characteristics. So again, here we go back to our table one, what we call like table one in manuscripts, which lets us understand why we have a more aggressive biology in this setting. In patients who had unclassified RCC in our study, they had a higher nodal disease burden and a slightly higher prevalence of liver metastases. So this might have kind of affected the outcomes over here. And this kind of lets oncologists know how to prognosticate these patients based on, based on the characteristics that they have in their tumors. However, what's interesting over here that even like the median PFS was longer and more clinically meaningful in patients with unclassified RCC versus patients without sarcomatoid features in their tumors. So again, we can kind of even see the benefit of the presence of sarcomatoid features, not only in Chromophobe, but also in papillary and unclassified, despite the lower overall survival and median progression-free survival. This is definitely a biomarker to keep an eye on. When we arrive to our oncoplot, many patients, try to ask us like, what is the meaning of this, and what we can how we can kind of make sense of it, and how does it usually guide clinical decisions? So here in that case, I just wanted to say that an oncoplot is a way for us just to represent in bulk all the mutations that the tumor harbor in these different subsets. We try to correlate these with outcomes, with objective response, with pathology and pathogenic. Again, so this is kind of, we're trying to build a puzzle together so that we can try to see which alteration is related to the best outcome. So in that case over here, we saw that the most frequent alterations were in TP53, around 42% of patients, and PTEN, 23%. And then in the third rank, there was also TERT, which is a 23%. And I'm just going to explain them in a few. Definitely know, Katie, that you are interested in, kind of in the meaning of these alterations. So the overall pattern that we received in this oncoplot is that it's a low tumor mutational burden as expected in RCC. So RCC is a type of cancer that usually doesn't have a lot of alterations. And then the TP53 mutations were common in Chromophobe RCC, which is like 8 of 9 cases, but they were absent in papillary RCC, while the TERT mutations were pretty much more enriched in papillary RCC. And this kind of would lead us to hypothesize whether the presence of like TP53 led to like worse or better outcomes to Nivo IPI, or whether the presence of TERT mutations just kind of led to worse or better outcomes in papillary RCC. But again, due to the limited number of patients over here, we could not make these confident assumptions. But however, one interesting observation that we could just try to tease out is that 4 out of 6 patients who had papillary RCC and 4 out of 6 patients who had unclassified RCC with TERT promoter alterations in their tumors, they had objective response to Nivo IPI. How can that guide future research? Probably this is a way to try to later on to stratify patients by these alterations, and just try to see like whether there is a particular response to that drug or to immunotherapy in patients who kind of harbor this genetic alteration. And specifically, there is interest in TP53, which is usually a negative prognostic factor. So the presence of TP53 is usually seen as a negative prognostic factor because TP53 is usually seen as the guardian of the cell. So when you have an alteration in TP53, the cell starts to proliferate uncontrollably. It loses its kind of cell feedback on itself. While TERT mutations actually means that there's an activation of the telomerase, and the telomerase is an enzyme that we have in our cells that just try to tell basically the cell that you can just have the signal of just living as much as you can, and you can kind of just keep replicating your DNA so that you can keep proliferating. So the TP53 signal in the alteration and the TERT signal in the alteration, they just kind of complement each other. So it's really interesting to see kind of how these would coexist together, and to try to know later on whether like patients who had both TP53 and TERT mutations had a different response to immunotherapy than those who do not have that. So the oncoplot here lets us look at this particular subset of alteration and try to hypothesize so that in future research, investigators would specifically look at these alterations and see different outcomes or patterns.
It's very interesting, and I think helpful to explain to patients kind of what I think if they've looked at a paper before, they might have seen these kind of like colorful charts and understanding kind of what those are. I know the total cohort for chromophobe kidney cancer was 12 patients, and I noticed 8 out of 9 are reported here with the um, TP53 mutations. Was that because not all 12 cases had sequencing done on them? And
Yes,
then
yes, yes.
um, my follow-up question on that would be then, if I'm interpreting this chart right, did two of the three chromophobe patients that had a response have the TP53 mutations? And then the third one wasn't sequenced? Did I read that chart right here?
Yes, absolutely. I get you, Katie. So just to follow up with your first question, definitely, yeah. Our NGS was identified in 26 patients, which kind of constitutes 47% of the entire sample. So less than a half of the population had genetic sequencing, but we are kind of the first group, thankfully, to have reported this data. And this kind of very insightful for later like clinical trials. And we kind of definitely urge our investigators and our colleagues to always try to report genetic data and to try to do sequencing in a centralized way so that we can try to see like how these alterations correlate with outcomes. And back to the three patients actually with chromophobe RCC who had objective responses to Nivo IPI, the right way to look at this oncoplot is over here. So we first go to pathology and try to identify in red patients with chromophobe, and those who had sarcomatoid features are patients here with an S, right? So if we have an S already, this is a patient who had a TP53, same as well over here. And the third patient who kind of had chromophobe with sarcomatoid features is not represented over here. Probably that means that they did not undergo next generation sequencing. But in the two patients, at least, who had a chromophobe with sarcomatoid features, both of them, they had TP53 and P10. Now, how these kind of just two mutations just connect with each other, that would be something to try to look at later on. But chromophobe RCC with TP53 alterations have a negative prognostic factor, which means it's usually associated as a marker of disease aggressivity. So that means that we're dealing here with an aggressive disease biology. So seeing that even despite the presence of this aggressivity in the tumors, three of these patients with sarcomatoid features still had response to Nivo IPI, means that the sarcomatoid feature really has some interesting just markers of responsive to immunotherapy that just try to overcome the resistance or the natural resistance of chromophobe RCC to immunotherapy. That's usually the message how I would try to interpret that in that disease setting over here in chromophobe.
Yeah, and that's very helpful. And I think the explanation of how to find those in the chart is really helpful as well, too. I think it's really important when we kind of show data, especially to those that are patients or not kind of involved in research, to be able to kind of explain how to read these charts. I know it took me forever to figure out how to read all of these things. So that's very helpful. Thank you.
Of course. And of course, this is based on low numbers, but probably the third mutations over here, I would say, are mutually exclusive with that TP53. So, and saying that most of these patients who are kind of these third over here had objective responses, this might be a hypothesis making process where we will later on in future studies try to understand literally kind of the prognostic impact of TP53 and its response to immunotherapy. As compared to the presence of TERT, where we kind of see this stigmata of response in patients, who had this alterations in their tumor and the objective responses to Nivo IPI. So this is also the third observation I would make out of this kind of oncoplot to see like whether the exclusivity of TP53 and TERT also tries to influence the outcomes in these patients.
Very interesting. Thanks.
Of course, we will not kind of just go into all of this table, but this is kind of a summary table that we just put in our supplementary file that just tries and helps investigators and researchers and patients try to compare the findings of our study to everything reported in clinical trials before. So we divide these by papillary, chromophobe, unclassified, and sarcomatoid features. The right way to try to look at it is to look at the CR and PR, which we kind of explained earlier in our study that these are kind of the parameters showing that the patient had an objective response to Nivo IPI in this disease setting. So having a higher CR and PR, or the sum of CR PR, is what constitutes the ORR. So the ORR is based on the sum of the percentages within the CR and PR. In chromophobe, for example, we see that a single agent ICI probably is not the best strategy to control this disease. We see, for example, an ORR ORR of 0% with Cabo plus Nivo, which is a TKI plus ICI strategy. Probably only we see some evidence in response with pembrolizumab and Chromophobe, which is here kind of, I would say, around kind of 10%. But again, in Chromophobe, we also see like an inferior response with cabozantinib plus atezolizumab of 11%. While here in our study, the 25% is seen in Chromophobe, and again, in patients who had sarcomatoid features. So we can, this helps us tease out probably who are the patients who are probably willing to respond to a PD-L1 CTLA-4 inhibition therapy in this disease setting over here. So the sarcomatoid features was identified as a biomarker of response in this setting. While it's definitely noteworthy over here that patients with Chromophobe, although they did not derive much benefit from Cabo plus Atezo or Cabo plus Nivo, we still saw a major response with lenvatinib plus pembrolizumab, which is an ORR of 28%. So here, in that case over here, I mean, I'm not gonna go into sarcomatoid features or not, because here we're kind of more into a TKI plus ICI strategy. But this is, we probably hypothesize over here that this response is mainly driven by lenvatinib. So this is definitely an interesting area or an observation that although Chromophobe was not responding to immunotherapy and the other disease combinations, here with lenvatinib plus pembrolizumab, we had an ORR of 28%. So it's interesting to see like whether this lenvatinib is driving the response or in this disease. And Nivo IPI, here we just kind of reported on this new finding.
Yeah, that's all really helpful context, especially all in one chart here. I'm curious on the Sunny Forecast trial, that one was kind of the most similar as far as kind of IPI Nivo both being in that one. So if we're talking about in the context of the Chromophobe, just making sure I'm reading that correctly. Is that 12 patients?
Yes, exactly. That was definitely an interesting study that tries to look at Nivo IPI in all variant histologies. So the Sunny Forecast didn't only cover papillary Chromophobe, but also it went into other subtypes as well. However, the exact distribution of, or like stratification of sarcomatoid features in every subtype was not evident to us. Definitely, I would like to try to look at the publication, but my understanding is that the particular granularity of the presence of sarcomatoid features was not covered in that study. So this is here where we kind of just try to compare and contrast with our study, just trying to report on the outcomes, the both survival, OS, PFS, and the response rates with patients with sarcomatoid features. Is something that we'd like to just to contrast to Sunny Forecast, where this was not mentioned to my knowledge.
I think what this chart really highlights is, I know a question that comes up a lot for patients is a question of why you might study the same thing or a similar thing over again. I know that that question comes up, especially with rare cancers like Chromophobe, of if you might see people doing similar strategies or looking at similar things, it might make you wonder, are those duplicative efforts? However, I think what's really important here is, while all these are slightly different, it kind of helps highlight the importance of how these can all combine efforts and be able to help learn overall when you look at them, kind of to help validate and say, is what we found through our study similar to what was found in other studies that are similar? They're not all one-to-one comparisons, but I think that's really helpful to see in a chart like this, to see how it helps kind of figure out if there's something that might be different about the thing that you're testing. Is that kind of the overall theme there?
Yes, no, definitely, Katie. And I think that the way how research goes can either be driven by two approaches. One approach is just literally going from bench to bedside. In the terms of you have preclinical evidence of the activity of or this drug, or even like this is a particular target that we can make it druggable, what we call druggable, just we can kind of target it, and then we can just go study that drug in that particular disease setting, so that we try to hypothesize on its outcomes. This is one approach in scientific research. Another approach is also based, I would say, more on observational clinical, where we see that a particular combination or a particular drug is working in another disease setting or another subtype. So we make a clinical trial that is focused on that particular drug and the most closely related subtype, or at least where we have some form of evidence that this drug might also have some stigmata of activity in that setting, which is a different approach from the first kind of bench to bedside. But I think the two approaches are necessary. They kind of complement each other in some sense. For rare cancers, it kind of make much more sense because, myself as a future oncologist, kind of aiming oncologist or training, or just kind of physician in training, I would definitely try to do everything that I can to give more treatments and more options for patients living with rare cancers, right? Because we know that it's more technically difficult to enroll these patients in clinical trials. So here, I guess sometimes we're going to have both of these approaches, like the bench to bedside and also the clinical kind of investigational approach, makes sense to try to see which treatment works best for these patients.
Yeah, that's really great. Thanks.
So this is just I shared with like two last slides of what key takeaways from our study is that patients with PRCC derived the highest clinical benefit from Nivo/Ipi, achieving the highest ORR and the survival rates and PFS rates as well, and the longest time to next treatment. While patients with Chromophobe RCC experienced modest benefit with Nivo/Ipi, however, the outcomes were greatly influenced by the presence of sarcomatoid features in 2/3 of the cases. Patients with unclassified RCC had kind of an inferior overall survival due to aggressive biology, but this has been explained by the higher prevalence of liver metastases and a greater nodal disease burden. So this helps kind of physicians prognosticate this particular subset of tumors in clinic. We also found in our OncoPlot that the presence of NF2 and SETD2 are present in these patients, and these are known to be associated with worse prognosis. The presence of sarcomatoid features was associated with a higher response rate across the three subtypes, papillary, chromophobe, and unclassified. And all the objective responses in chromophobe and most in unclassified RCC occurred in patients with sarcomatoid features. This is definitely a biomarker that we should investigate further in our research in non-clear cell kidney cancer. When we want to compare our study with the clinical trial of like Checkmate 920, which you can say that they both studies that had similar treatment naive metastatic status. That means patients did not receive lines of treatment before Nivo/Ipi. It was kind of the first line, frontline systemic treatment for the advanced disease. The histological subtypes were also pretty much similar. They focused on papillary, chromophobe, and URCC. And the prevalence of sarcomatoid features was largely also comparable between both studies. The median OS was also largely comparable, which kind of gives us more confidence about our results. However, our study reported a higher ORR of 36.4% with Nivo/Ipi versus 19.6% in Checkmate 920. The primary tumor response was like 33% with more than 30% diameter reduction, which is kind of similar to Checkmate 214, 35%. Why is that important? We also kind of try to prove over here that Nivo/Ipi is able to even reduce the primary tumor, the kidney tumor. So usually people usually tend to forget about the origin or the primary tumor in the metastatic setting, but actually this gives you more window to surgical consolidation. If the treatment is also able to reduce the primary tumor, this might be an opportunity for the oncologist and for the urologic oncologist to try to take out the primary tumor. The evidence about that in the literature is still kind of more investigated, but there is also some early evidence that if you have a systemic treatment, particularly with immunotherapy, where you can kind of shrink the primary tumor and you take that to surgery to take it out, probably the patient might benefit from a better survival if we take that approach. The treatment associated adverse events were largely comparable, so we did not find any new signals. There were no fatal events, thankfully. And at the clinical benefit standpoint, we know that the durable responses allow treatment discontinuation in subset of patients, again, as seen in Checkmate 214 follow-up, where we know that the treatment with Nivo/Ipi can give for the patient a window just to stop treatment and go off treatment for a long period of time.
That's very helpful. I actually was going to ask one quick question on the previous slide. So I notice that you mentioned here that there's a higher ORR in your study. I also noticed that there's a lower rate of discontinuing due to side effects. Do you think any of that might have had to do with the fact that patients were able to stay on treatment longer in kind of looking back retrospectively at your data, or did you guys have any hypotheses about why there might have been a higher ORR in your study?
Of course. Definitely, Katie, that's a question we asked ourselves. However, this might be a bit harder to tease out because, again, I guess it's more related to the methodology. Our study is an observational retrospective series, while the clinical trial is usually more done in a more controlled setting. So sometimes the radiologists, the readings might differ, the methodology, the definition of response might differ among radiologists. Again, we are all humans, and sometimes the human factors might intervene mean in the different interpretation of the responses and how much it has durability. And again, this is one limitation I mentioned in retrospective series, is that they are usually done in a single center. So this is a single center institutional experience. So the way how kind of sometimes the oncologists treat these patients might differ, or the approach might be different from the approach that is used in a clinical trial where we have multiple investigators and multiple collaborators. So this is definitely a variability that we expect to see. Usually we can try to compare real world evidence to clinical trials. And I really appreciate that always kind of patients keep this in mind when they just try to compare and contrast studies, that we're always limited by the normal methodological limitations that do not allow us just to make exact kind of compare and contrast approaches. But I guess as even regardless that we have a higher ORR over here, and although the methodology might sometimes differ, I guess the signal regarding on the survival as well as the main disease characteristics just allow us to say that there is evidence of response to Nivo IP across the three subtypes, most specifically in patients with sarcomatoid features across the three subtypes over here. So that is kind of the extra information that we've been trying to tease out when we compare our study to Checkmate.
Yeah, that's helpful. Thanks.
In the end, I just wanted to thank many different people, mentors, co-workers, patients, and advocates. Definitely, I would like to thank my main mentors, Dr. Matt Campbell and Dr. Omar Al-Halabi. Their support has been essential in my journey, and without them, I really could not cannot try to look at this important piece of information and share it with our community. I would also like to share Dr. Nizar Tanir, who's a leading person in the field who just kind of fought literally with everything he could just to try to push research further for patients with like rare cancers and especially in the area of kidney cancer. I definitely learned from him. We all learn from him. So he's a major inspiration for me. It's been an honor to have this work mentored by him. I also thank my colleagues at work, our MD Anderson GU medical oncology research team. Another area of research of interest for me is actually bone metastasis in kidney cancer. And Dr. Campbell is leading a wonderful group to try to make outcomes better for patients living also with bone metastases and kidney cancer. And finally, big thanks to Katie. Your support has been most tremendous to me, not only in conferences, but also in every step that I do. You really made me know the importance of knowing why this research is important, not only for me as a researcher. And in the end of the day, people might look at academic prowess and just try to publish papers and say that this is something that we can put in our CV. But in the end of the day, we do this for our patients to try to make their outcomes better. And because all of us can be affected by cancer, and every patient has the chance to just have good treatment response and good outcomes and have lived the best life as possible. So definitely thank you for reminding me of that. And I really appreciate your time and consideration over here.
Yeah, thank you so much. And thank you for sharing all of this with us. I think this will be really helpful for patients. I think the one question that I'll probably leave us with here is if there's anything that you could share with patients who are affected by chromophobe kidney cancer. Do you have anything that you would like to share with them?
Definitely. Thank you so much, Katie. So in my position, I've been allowed to shadow my mentor in clinic, and I definitely have seen a lot of patients with a huge scope of different rare cancers. So my advice over here to Chromophobe RCC would be the same as to all patients living with rare cancers, is to try to educate yourself, try to always be the active investigator who tries to understand and put together all of the data and talk about it with your oncologist. It's okay to ask questions. It's okay sometimes to doubt things. We are faced like with a huge load of information nowadays, not only from AI, from Google, from all different things. I know it can be all confusing and everybody wants to have the best the best answer to their questions, but always kind of connecting with patient advocates, with patient advocacy groups is super essential, because like the work, for example, that Katie has been doing, for example, I might be biased over here, but the work that she has been is like very essential to try to collect all the data from patients, even from all over the world, and put it together. This might help us one day just make a hypothesis or just try to find a particular pattern. And this allows patients just to have a voice and share that with their oncologist. Of course, research is tedious. Research takes time, and we all kind of wish if research was able to go faster to try to come up with different outcomes. But I just wanted to say that, well, if we all put our hands together, hand in hand, we can just try to learn faster, make progress faster, and get to advanced science faster. It's really something that cannot be done without collaboration between oncologists, different providers, our healthcare practitioners, even patients, patient advocates. If we put our hand all in all together, definitely I think we can advance science faster than if we do it just like individually. So I'm really grateful to you, Katie, and every patient advocate that just tries to spread awareness about like disease and particularly about rare cancers.
Yeah, thank you. That's all super important information. And I also think I really liked what you highlighted about patients advocating for themselves. And I think that really kind of brings us around for what patients can do with this information, right? This is information that is kind of meant for research and educational, right? But where it can be really helpful is these can be the pieces that if you know about this study and you know about this data, you can take that information and have a conversation with your care team and ask them if they've seen that data or that information, because it can help present them something that they can use their experience to interpret in your case specifically. And so I think that piece is really key. And I really like that you highlighted that because it gives a way for patients to feel empowered by this information in a way that can help in their own care, but in a way through the lens of their oncologist. So thank you so much for sharing this data and information with us.
Thank you, Katie. Appreciate it. Totally agree.